Hello and welcome to VIP Vet Talk. Veterans in Pain facilitates orthobiologic and alternative solutions for veterans suffering from chronic pain by connecting volunteer physicians with our country's heroes nationwide. Dr. Steven Reichbach is the director of our ketamine division and is joining us today to discuss intensive ketamine therapy and its application in the healing of service-borne conditions in particular, and the centralized systemic diseases that are plaguing the veteran population, and to tell you that solutions do exist. Dr. Reichbach, thank you so much for joining us.
Glad to be here, and thank you for having me, Michaela.
I would love to know if you can share with us while I have you, your experience treating our veterans.
So we basically treat, for the most part, two subsets of patients. And the first being patients with certain mood disorders, specifically PTSD, major depression, treatment-resistant depression, anxiety disorders. And the second being patients with certain chronic neuropathic pain syndromes. The common ones, fibromyalgia, CRPS, complex regional pain syndrome, phantom limb pain. And a lot of times there's crossover between the patients. The patients that we have treated, that we've gotten from you guys, have been nothing but a total pleasure from every aspect of it. They've all been dealing with PTSD. That's a given. Depression and different types of mood disorders, and for the most part, certain pain issues. Whether it's directly related to their service or not related to their service. And they have been so appreciative of everything that we've done. They are funny, they are engaging, they are just, salt of the earth people that, anything that we can do to try to help them in any way has been just extremely rewarding and satisfying for all of us working here. So that's kind of how it's gone for us so far.
That makes me so happy. I have to tell you that our feedback from every single veteran has been how welcomed they felt and the difference that you've made in their lives simply by how you treat each patient that comes in the door. And our veterans, they mentioned, I received VIP treatment. Right?
Well, it's only appropriate, isn't it?
That's the point, right? That's the whole
100%.
That's the whole agenda here. Yeah. So I have a question for you in regard to TBI. How does ketamine approach the treatment of TBI?
So specifically treating TBI, a large number of our patients have been through, whether it's physical traumas, emotional traumas, accidents, active combat. And what we found anecdotally is in treating corresponding PTSD or pain issues, patients with TBIs to a large degree seem to have improvement in their symptoms, their TBI type symptoms. The anxiety, the agitation, the language issues, the communication issues seem to a large degree get better treating them with ketamine. And it sort of makes sense because the whole idea of ketamine and how ketamine works to help patients that are struggling with these issues is kind of a rewiring of the brain and the connections between the brain, and causing parts of the brain where the mood is responsible. It's a reorganization, and neurotropins are released, and there's regeneration of nerves in those regions, and improvement between the connections, the dendritic connections. And that seems to correspond to a large degree to a positive response. So patients with TBIs, it seems to make sense that if that's the hardwired change that's thought to occur, that you may see some improvement in a lot of issues and a lot of the manifestations that they're exhibiting from their TBI.
Because of my personal experience with ketamine infusions is what incited our interest in bringing ketamine therapy and opening this division led by you with veterans in pain, and for our veterans suffering from CRPS, TBI, PTSD, systemic inflammation. My own experience was through UCLA with Dr. Joshua Prager, who is one of the foremost experts in CRPS and the secondary autoimmune conditions, chronic pain diseases that are ranked number 1 and number 2, I believe, are complex regional pain syndrome and arachnoiditis. So with ketamine infusions, from what we understand, and tell me whether or not I'm correct or not, this is occurring on almost a cellular level, where normally we have inhibitors, correct?
Yeah.
On a cellular level, which then if you bump your knee and you have pain, it's kind of like if you're bouncing a ball, gravity would be the inhibitor. It would stop the ball from bouncing gradually. But with CRPS, arachnoiditis, and these more systemic manifestations, a centralized systemic nature of chronic pain, these inhibitors are no longer present, correct?
That's correct.
Okay, so
correct.
Signals just keep going and going and going, and then they can become systemic and traveling to different areas of the body.
That's correct.
Okay.
So what starts off as a peripheral injury or peripheral, most patients with CRPS, they'll have surgery on an extremity, or they'll twist their ankle, or they'll have some kind of issue with their hip, and time goes by and things keep getting worse. They don't get better, and time usually heals most of these type of injuries. And what happens is they develop pain that becomes way out of proportion to the actual source of what caused it initially. And, unless you're keyed into knowing about CRPS and how it presents and how it manifests, and the temporality of having an injury and then subsequently developing these certain characteristic signs and clinical symptoms that are associated with something like CRPS, it's almost like a computer that you feed data in, and you stop feeding the data, but yet the computer just keeps going, and then it keeps going faster, and then finally it just starts smoking and stops working altogether. And it's what we call central pain, differentiating from peripheral pain. And the central pain is just, the pain just begets more pain. And the longer this goes on, until you get it under control, the pain pathways broaden, they intensify, and the role of ketamine is really, ketamine is most beneficial for patients who are exhibiting centralized pain, sensitization, desensitization. And it basically blocks those pathways and lets that whole system kind of reset itself. So the ultimate goal is that you're left with pain that would only be proportional to something that would be acutely causing it at that point.
So when we're talking about PTSD, TBI, CRPS, chronic pain as the centralized systemic condition, they all have one thing in common, and which is the lack of these inhibitors, as well as systemic inflammation or brain inflammation. So
Absolutely.
Can you please address how ketamine therapy, number one, what are the basics of, if you had a 1, 2, 3 ABCs on ketamine therapy, how does it work?
Sure. So NMDA receptors and methyl acetate receptors are the most prolific receptors connecting the spinal cord to the brain. So when there's an impulse that, let's say you hit your foot, it travels up through your spinal cord, goes through NMDA receptors to the brain, it's interpreted by the brain, and then it's sent down the motor pathways back to cause a response in there. What happens when you develop central pain is that connection, those NMDA receptors that connect the spine to the brain are in hyperdrive. They're just going. Nothing is inhibiting them. They're being stimulated constantly. And what the ketamine does is it acts as an antagonist to those NMDA receptors, blocking them. So that those continuous transmission of those pain signals is blocked for that period of time. So what you're doing is basically stopping that whole cascade from occurring for a period of time. And the idea is, if you can do that for a long enough period of time and block enough of those receptors, that's the main way that ketamine is thought to inhibit a lot of these pain that's exhibited in patients that are exhibiting centralized pain. The other important thing to remember is ketamine itself is a fabulous central nervous system anti-inflammatory drug. So a lot of symptoms, a lot of pain, I just read a study where they think that a lot of patients exhibiting irritable bowel syndrome, a lot of it is due to centralized pain, and they're experimenting with giving these patients ketamine to see if it helps with some of their symptoms. So there's always issues with central nervous system inflammation, and so ketamine helps in decreasing that as well. It also acts on the descending limb, on that motor pathway, where there's inhibition. So a lot of times you'll get some pain impulses that pass through. It enhances that inhibition, those inhibitory pathways that were sort of not allowed to work properly because of the disease entity that patients were struggling through. So it's really three ways that it's thought to work in that capacity to help patients.
You know, one thing that is so fascinating, and one of the I don't know if it's a metaphor, but it's kind of like it basically reboots the brain down to its most primal state, correct?
Yep.
Kind of separating the nervous system from the brain a little bit, right?
Yeah.
Okay.
Yeah.
Allowing it to calm, allowing it to reboot, like
exactly.
Right, impeding the craziness that's occurring.
Impeding the craziness, exactly.
So there's a difference now. A lot of people, they hear about ketamine and they're like, oh, it's not natural. Oh, we've had issues at the VA with dosing or side effects or an inability to obtain the microdosing from the VA, and then outsourcing and trying to find it on the black market. And having these OD rates go up. It's a lot of misinformation, although some of those are facts. The way that ketamine is distributed with you and through this therapeutic aspect of this protocol is actually very intensive, and it isn't something you can do at home, and it has nothing to do with taking a pill. So can you explain this process? Somebody comes to you and they're accepted for ketamine therapy. Yeah. Can you walk us through that process?
So just to kind of lay it out there, ketamine itself is a relatively safe drug. Having said that, you can get changes in blood pressure, you can get changes in heart rate. It's in the class of drugs known as dissociative medications. So typically for patients that we treat for mood disorders where the doses are relatively low, it's generally a very pleasant, warm, comforting feeling going through the experience, the dissociation, the mind out of body experience. In higher doses that we generally use to treat these neuropathic pain syndromes, patients will start to hallucinate. And we have to be very careful and very, aware that especially patients who have been through a lot of trauma can become extremely uncomfortable at higher doses of ketamine. So we treat them with sedation. We keep them sedated so that they tolerate the infusions well. They're continuously monitored for heart rate, blood pressure, breathing. And so the idea is that we titrate the amount of ketamine. It's easy to titrate when it's done intravenously as opposed to orally or nasally or intramuscularly, because if patients get uncomfortable, we slow the infusion down, and within a minute or two, it tends to subside. If they're tolerating it and we want to try to infuse more ketamine, it's very easy to increase the rate of the amount of ketamine that they're getting and see how they tolerate it. We're continuously monitoring their mental status, and I know what to expect at certain doses, and if somebody's doing something they shouldn't do, we correct for it. This is not something that you'll be able to do if you're at home or you're going somewhere where it's not easily titratable. When you give ketamine, when you administer ketamine intravenously, 100% of it is going where it has to go. There's no bypassing, there's no metabolism of it before it gets to the brain. There's no going through mucous membranes in the mouth if you were using it sublingually or through the digestive tract, if you were taking it orally, intranasally. So for me, really the gold standard to try to see if ketamine is going to be effective for treating a lot of these disorders is to administer it intravenously where it can be easily titrated. And what the dose that you may tolerate for the same exact condition may be 3 times as much as I'll be able to tolerate. And a lot of it is based on, when I say tolerate, what you'll tolerate as far as the psychomimetic effects of it, let's say, or the cardiovascular effects of it. So everybody is different, and it's the only way to really do it in a proper way is to administer it, in my opinion, intravenously.
I remember when I went through mine, we began, and everybody should also understand this isn't a one-day treatment for
Right.
these more intensive conditions.
Absolutely.
Okay, more advanced conditions. So for me, my experience was I went in, I was in a medical setting, a clinical setting, and sedated. And we began on day 1. Mine were 2 weeks long, 5 days a week.
Yep.
From 10 a.m. until 4 p.m. for me, highly intensive IV ketamine therapy, beginning with a lower dose. The next day, they brought it up a little. Next day, they brought it up a little, and so on. So I was essentially in what they called a ketamine coma during this period of time. However, it left my body very quickly.
Yep.
By the time I got home or to the hotel at 6 o'clock, I felt virtually normal, only immediately I felt very clear. And by the time I was done with treatment, and my own condition, again, was arachnoiditis complicated by CRPS of the cervical spine. So both of those are called on the McGill pain scale for 1 to 10, are designated as 1,000 and are called the suicide diseases.
Yep.
So, understandably, this was virtually my last resort prior to discovering stem cell treatment, and which for me, I would not have lasted the way I did without the ketamine infusions and the chronic pain program. And I think what is so important to emphasize is the marriage of modalities and approaching healing in a holistic perspective. And ketamine is a very powerful tool. Orthobiologics is incredibly powerful. Pain psychology, physical therapy, neurobiofeedback, cryotherapy, ozone therapy, all of these elements work best together. And they complement one another in all the ways that, if alone, most best optimal results are really found. I would love your perspective on that. And what do you recommend to your patients once they go home in regard to support measures?
So basically, the important thing that I would like to get across is that the patients that we get inquiries from, this is not their first stop. They've been through it, and they've been through all the meds. They've been through physical therapy. They've been through hypnosis and, warm water, warm pool exercises, and all the modalities that you've mentioned. And they're looking for an alternative. And very often they find the alternatives themselves, because physicians aren't even clued in a lot of times to many of these diseases, and patients will go undiagnosed with something like CRPS or fibromyalgia for a long time, and it just frustrates the practitioners. So patients are working on their own to try to find alternatives.
So in speaking about CRPS, complex regional pain syndrome, can you please share with our listeners the symptoms of this condition and how they might arise?
Sure. So typically, as you alluded to before, CRPS generally starts with an injury to an extremity. It could be that you had some kind of trauma, surgery on your hand or your foot. You twisted your ankle, you separated your shoulder, you did something that ordinarily time or surgery or some medication for a short time would cure the problem and the pain would decrease. For an unlucky subset of the population, and for whatever reason, whether it's genetic or not, they develop a syndrome where the pain starts to intensify over time in that extremity. The pain becomes really burning nerve type pain, electric shock. There's certain criteria known as the Helsinki criteria that you look for when you're trying to make a diagnosis of CRPS, which is really a diagnosis of exclusion. So, you do x-rays, nothing really shows up. You do lab work, nothing really shows up. You do nerve studies, muscle studies, nothing really shows up. So what are you left with? Well, you're left with severe pain that can't be explained. It's often associated with discoloration in the limb, a lot of times, swelling, changes in hair growth and nail growth in those extremities. But probably the symptom that is most closely associated with a diagnosis of CRPS, centralized pain, is allodynia, which is basically when you touch the skin, shouldn't ordinarily cause any problem, can cause excruciating pain. Taking a shower, almost impossible because the water hitting the skin will send the pain levels, out of control. That's probably the most important question to me in trying to make a diagnosis of central pain or of CRPS, is the allodynia, in conjunction with that burning pain. So when we see them, like I said, it's not their first stop. If they sound like they have the type of story and whether they come with the diagnosis or I make the diagnosis, if I feel that they are going to benefit from it, then I tell them, hey, this is what I think. These are what the realistic expectations are, but it's not the be all to end all. You may get some relief from this, major improvement in your function and your quality of life. It gives you the ability to now maybe do physical therapy that you weren't able to do before. Get in a warm pool and start pushing it a little bit. Therapy, talk therapy, all kinds of, once you're feeling better and, you're more open and you're not in so much pain and everything is clear and your cognitive function starts improving, because how could you be at your best when all you're thinking about is getting through the day because you're in constant, agony with pain?
It's such a great point. I'm sorry to interrupt you. That is
that's just, one of the things, as you probably, I'm sure you do know, is it's not just physical stressors that can flare up and cause issues with patients with CRPS or RSD. Your emotional state, stress, physical stress, emotional, mental stress can cause flare-ups. So the whole idea is when we're done with these infusions, hey, you still need to figure out how to life is throwing darts at all of us, and it's going to be stress after stress, but how you deal with it and how you're able to accommodate for all of these things without it causing you to, for that computer to start, revving up again is really, really important.
You're touching on something that I rarely hear about, and this just incited this thought. The order in which we approach the different therapies can also be the most important aspect of utilizing a holistic approach, because I was going to physical therapy and I was doing all of these things that just put me right back in bed. If I had only found the ketamine solution sooner, they tell you need to do all of these conservative measures before you can do anything else, or they send you right back. I had 20 spine surgeries and every single one would make it worse and would make it worse, but they're trying to create a solution when if you don't quell the insanity within the body first. I find that ketamine therapy was the clearing of the canvas so that we could create this masterpiece ultimately of health and healing. And because of that, and in combination at the same time with certain measures, like part of the program was pain psychology after that. But we did ketamine first for the first 2 weeks. And then for the next 4 weeks or so, from 8 a.m. till 5 p.m. I would have a pain psychology appointment at 8 in the morning. And then at 10 a.m., I would have physical therapy. And then I would have biofeedback. And then the next day, we'd begin with soft tissue therapy and so on. And then also incorporating the Western medicine measures, such as prescriptive therapy. It's important to balance everything. But without those first 2 weeks, or for most people, it's 1 week of intensive therapies to quell that, like I said, quell the mania, none of the rest would have been as effective or efficient. Now, everybody's different, but I think people assume ketamine itself is a last source measure. And I would love for them to start thinking differently and opening their mind to this magnificent science that that is so, I experienced it as being very clean. And I tell everybody, by the time I was done with ketamine, it literally was as though somebody had washed the windshield. Like, I've been living my life with, and I didn't expect this. I was looking for pain relief. But as soon as I was done with the treatments, it's as though I was living with a dirty windshield for 8 years, and I got used to it. And yet somebody washes it and it's crystal clear, and my sensory is different. My experience of the world is different. My relationships are different because I don't have this cloud between myself and my loved ones. It's sorry to go on, but it's
you're describing what we hear every day. The other thing that I would kind of just want to make clear to patients or people that are listening is the patients who seem to get the most profound response are patients that are treated earlier rather than later. So if you've been diagnosed with something like CRPS or fibromyalgia or phantom limb pain, whatever the case, trigeminal neuralgia, ketamine, just probably like anything else, the sooner you start treating, the higher the likelihood that you're going to have a profound benefit from it. So patients who have been struggling for 5 or 10 years and the CRPS, the pain has spread from the right foot up to the left hip, and now they're having upper extremity issues. It becomes much more difficult to deal with patients who are exhibiting more total body CRPS rather than having it isolated to a native site. So it really should be at least on the radar for physicians to, once they've tried all of the more conservative measures and patients have not really gotten the benefit or the help that they ultimately are capable or hopefully that they're able to get, think ketamine as early as possible. Ultimately it's got a very, it's got a negative connotation on the street. It's a horse tranquilizer, K-hole, this and that. But I can tell you that it can have some life-saving and extremely profound benefits for the right patients. And we have not seen very many patients that have been diagnosed with CRPS that have not benefited, at least to some degree, from these ketamine treatments. That's what we've seen.
This is the issue that we're having with veterans today in their inability to receive the proper treatment, only due to the physician simply not being aware of CRPS and its nature. So when a veteran has joint pain, develops into CRPS of some kind, they are sent to an orthopedist, and it's treated joint specifically. And otherwise, they're sent to psychology. And you're literally, it's like looking at a broken leg and wishing it well in doing so, because it's a mechanical condition. If this offers any validation whatsoever to veterans who are having these systemic conditions develop without any guidance or support or validation that they're very real. And just because you can't see something on an X-ray, arachnoiditis, and this is the other condition that we mentioned, right? So when you have a puncture of any kind, any type of injection, it could be a mother going in to have her very first child and having an epidural. Then a matter of a couple of weeks, you can lose the use of your legs. And within your spinal cord, any pressure to the tailbone can end up having literally labor type contractions within the cord. That's why so many veterans have to lay in bed for years. Myself was 6 years, because you can't put pressure on the tailbone. And yet everybody thinks you're crazy because it doesn't show up in an
Well, it's frustrating for them because they want to know what's going on and they want to fix it, but they can't. They something's missing. So it's easier to not blame the patient, but it's easier to say, oh, this is all in their head. This is not real. The pain can't possibly be that real.
Right.
The other thing to mention really is that for a lot of these type of central pain syndromes, patients are prescribed narcotics, and the narcotics themselves over the long term are going to make things worse. You're going to develop hypersensitivity, and the pain of CRPS is not going to respond that well to narcotics in the first place, but if you're taking them chronically, your pain level is going to go through the roof the longer you stay on the narcotics. So, when you are able to kind of put the whole picture together and get the pain level down with something like ketamine, then you can talk about weaning off the narcotics, which we're probably not doing any good at that point anyway. And, that becomes a whole other issue, trying to wean a lot of these patients off narcotics when they've been taking them for such a long period of time. But if they're not taking them to treat the pain and it just becomes a matter of detoxing or weaning off of them safely to avoid any significant withdrawal, it becomes a lot easier from that.
Now you just nailed it. You just nailed something that nobody talks about opioids and their effect on sensitivity in these centralized conditions. That's very rarely spoken of. Everybody talks about the effect to the liver or to your stomach or to your heart. But nobody talks about how it can actually exacerbate pain levels. And so pain levels continue to rise. So the solution would be, oh, well, let's put in a pain pump. Oh, so then again, you have an intrathecal catheter that's entering the epidural space.
Just another source of a flare-up.
Absolutely. And so, with arachnoiditis, if you have one puncture, many of us with spine or our spine patients have had dozens, whether it's any type of injection or steroid injections. Sometimes they do epidurals for spine patients to get rid of the pain.
Absolutely.
But when you have anything that interferes within the lining of the dura, that launches an autoimmune response. And within the cord, it's arachnoid, like a spider. The body tries to defend itself, and in doing so, creates plaque around the nerves within the dura of the cord, and they harden. As far as Western medicine is concerned at the moment, I say Western just because it's something we can relate to and is an alternative to orthobiologics, biologics, and alternative solutions. But as far as Western medicine is concerned, there is no cure for arachnoiditis at all. There's no cure for CRPS. I'm sitting here today as a living example, as are your patients and our veterans, to say there are solutions. You do not have to live with it this way, that these solutions do exist and they're here for you. Now, the important thing is to understand, do your research, and connect with organizations such as Veterans in Pain and other pain-related organizations, EDU sites, .gov sites, .med sites, PubMed, to find the physicians that are actually performing these properly and utilizing the proper products that are created in the proper lab. And that's where a lot of these bad case sources evolve on the internet, is from physicians who are either diluting their product in order to have a greater bottom line, or they're deploying them in mass, or they're not deploying them properly, or with the time and consistency and concentration that you really need. So education is key. That's what we're here for. I cannot thank you enough for joining our program, for embracing our veterans, every single one we've sent to you, And it's an invaluable therapy that we hope we can only bring further and further to the masses, especially in the veteran community and population, where these service-borne conditions are consisting mostly of these degenerative and centralized systemic chronic pain diseases. Okay, so one service-borne condition, which is deeply affecting our veteran community, is called burn pit. Burn pit is an effect of toxic exposure. And so in Iraq, in Afghanistan, there are what they call burn pits. They are acres of land. It could be 1 acre. It could be just a hole in the ground, up to tens and dozens of acres, where they're pre-existing pits. Our military utilizes them to dispose of almost anything you can imagine, from nuclear waste, chemical waste, to body parts, to furniture, to ammunition, weaponry. The list goes on. If you can imagine putting it into an incinerator, that's what these pits are for. Our troops were assigned to man these burn pits as they're burning. Our encampments are within the vicinity of these burn pits. Our veterans are sleeping, respiring. The skin is the largest organ in the body. When they're standing and manning these pits, they are inhaling it, respiring these toxic chemicals, not only into their body systemically, they're inhaling them, and it's damaging the lungs. The bronchi are collapsing. So there are certain things that you can see on a scan. However, what's affecting our veterans most is this massive decrease in oxygen distribution to the body. So, number one, we have systemic inflammation and of the brain due to the blood-brain barrier. You're having inflammation in the brain, which is causing involuntary functions of the body to malfunction. So suddenly you have heart arrhythmia. Some of our veterans with burn pit exposure, and it is a condition or toxic exposure, for lack of a better term, these veterans are having a resting heart rate at times from 200 to 300 beats a minute. That's resting heart rate. So then they're sent to a cardiologist who can find nothing wrong with their heart, or they have sleep apnea, or they're snoring more than they ever have. These involuntary functions of the body are being affected, yet the lack of awareness as to the systemic effect of toxic exposure is the awareness of that is so very limited. And so again, it's like having a systemic chronic pain condition, that you have knee pain due to that, but yet they send you to an orthopedic to treat the joint, when actually therapeutically it needs to be addressed systemically. So with burn pit syndrome, they have decreased oxygenation, and so they can't walk up a flight of stairs without being completely out of breath. The systemic inflammation is causing these chronic pain diseases within their bodies, and yet, again, no opportunity for diagnosis. We work closely with the Veterans Administration. We actually facilitate procedures for certain administrations for veterans that need help beyond the measures of what's accessible within a VA. But right now, the VA itself is they don't have a clinical diagnosis or coding for chronic pain as a centralized systemic disease. And so therefore, our veterans are struggling more than ever, right, to find these types of solutions for this. So it's being distributed through the body in a way that it's not only causing those conditions, such as symptoms of TBI and PTSD and heart arrhythmia, but actually festering wounds that won't heal on the outside of their skin, as well as cancer. Cancer is proliferating through the population of these veterans who have manned these burn pits. So I would love your feedback or your thoughts on ketamine infusions and addressing this aspect of service-borne conditions, if you have any thoughts on that.
One of the patients that you had sent us was dealing with a lot of symptomatology related to the burn pit, but it sounds like issues such as these, no doubt, IV ketamine infusions really, to me, there's no downside. So a lot of times the only way to find out is to try it and see if you get a response. If you're going to try to treat somebody for something that you have a pretty good idea it's gonna help, let's keep an eye and see if it's helping with these other issues that might be related to the same thing. Because what we learned from one patient, we can apply to other patients. And if we get some information on ketamine helping patients that are treating for PTSD, but they have these other issues related to, the umbrella diagnosis, well, when someone else comes along and has these conditions of it as well, we can tell them, hey, in our experience, this makes sense that something like ketamine could help with these other issues as well. And so, to me, the threshold to try ketamine on patients who are struggling, with all the things that we've discussed, mental health or chronic pain, is extremely low. I mean, there's very few patients that I would not try ketamine on, unless you're actively psychotic and diagnosed with schizophrenia, or you're in a hypomanic or a manic episode, having been diagnosed with bipolar disease or liver failure. Under the right circumstances, there's really very little reason not to try ketamine on a patient who is struggling, to the point that most of the patients that we see are.
Is cancer a contraindication for ketamine therapy?
Absolutely not. So cancer is actually, I'm glad you brought that up, because we see a lot of patients who are on high doses of narcotics to treat stage 4 cancer, and the pain can be unbearable. Patients that are given ketamine in conjunction with narcotics seem to have a much better impact on their pain levels. So ketamine is a great adjuvant in trying to treat pain associated with cancer. Sort of as a side benefit, what we've also seen is that patients who've been diagnosed with cancer, without a doubt, are struggling with severe anxiety and severe depression. That's just part of the diagnosis of cancer in our society. And the ketamine we're finding is having, tremendous benefits with respect to helping with the depression associated with that diagnosis, helping with the anxiety associated with that diagnosis. So we encourage patients who've been diagnosed, who are struggling and being treated, if their anxiety and if their pain, if their depression as a result of it is really becoming significant, I think ketamine is a great option for many of those patients.
I have a question for you in regard to the anti-inflammatory nature of ketamine. Do you think there are any therapeutic or healing qualities for those? It's difficult to say. I understand that it's a very sensitive topic. Is there a therapeutic element to it? And secondly, in regard to the benefits of ketamine therapy in general, on average, how long have you seen these effects last in your patients? And is there a booster that's needed, or can you address both of those?
Sure, absolutely. Again, very variable between patient to patient, depending on what their clinical condition was when they presented to us. As I said, patients who have been treated earlier rather than later seem to have a more profound response to the treatment as far as their pain levels and all the other associated symptoms that go along with the diagnosis. They tend to get a longer period of relief after the initial infusions that we do. We'll generally do anywhere between 3 and 10 initial infusions on patients who are coming specifically for certain neuropathic pain syndromes.
And that's, I'm sorry, and that's in a row, correct?
Correct.
Like
That's
Monday.
correct. We try to do them consecutive days, right?
And then after that initial intensive therapy,
Sure.
on average, what do you see the length being of benefits? And are they?
I would say probably average, we will do booster infusions 2 to 3 times a year on those patients, whether they come in. It's generally for two infusions, 2 to 3 infusions on consecutive days.
And then when they do you see the initial clinical presentation slowly subside as time goes on with these additional treatments?
That's the idea. And a lot of it, again, is assuming that patients are able to live in an ideal world and do everything that they're supposed to do in between these boosters. Then, yeah, over time, the length of time that they're able to go between boosters just keeps getting lengthened.
So again, this revisits the whole concept of ensuring that this can lay the platform for incredible results, for additional adjunct measures to actually take hold and take root, and to the point where you've reached a quality of life that you never thought you could have. I know that I received mine. I just can't thank you enough for all you're doing.
Well, thank you for inviting me to be a part of your team, because it's been a wonderful experience so far, and I hope that we can continue it for a long time to come.
Thank you very much. Thank you for joining us on Vet Talk today, VIP
Sure.
Vet Talk. And again, our website is veteransinpain.org. We look forward to receiving any applications from physicians and from veterans across the country who would like a tangible experience in healing. Thank you very much. Have a wonderful day. Our gratitude is endless to you.
Glad to be here, and thank you for having me, Michaela.